Okay, I think we are ready to begin. My name is Alexandra Hunter. I am a final year grad perio resident at the University of Toronto and one of the members of the OAK Seminar Committee. I want to thank you all for registering for this exciting lecture from Dr. Bhide regarding the site-specific approaches to treating gingival recession in the anterior mandible. Before we get started, I wanted to go over some of the housekeeping. I'm your host, again, Alexandra Hunter. I just wanted to ask everybody, if your microphones or cameras happen to be on, please turn them off during the presentation. And of course, I'm sure many of you will have questions. So at any time throughout the presentation, you can go to the chat button and you select moderator as the recipient, and the moderator is going to, the moderation of the question is going to be done by 3 of my wonderful co-residents at the end of the presentation, and Dr. Bhide will be happy to answer your questions. The presentation will be recorded and will be available for you to review if you happen to have to leave early tonight. The presentation is expected to be just over an hour and 15 minutes, with a 30-minute question and answer period at the end. So I just wanted to introduce Dr. Vinay Bhide. Dr. Vinay Bhide is a board-certified periodontist. He completed both his dental schooling and periodontology specialty training at the University of Toronto. We're so lucky to have Dr. Bhide as a clinical instructor in our graduate periodontology program here at U of T. Dr. Bhide mainly works in private practice, but he can also be found at the Center for Advanced Dental Research and Care at Mount Sinai Hospital System in Toronto. Additionally, he is an examiner for the Royal College of Dentists Canada and a diplomat of the American Board of Periodontology. Most recently, Dr. Bhide was appointed as adjunct assistant professor in the Department of Periodontology at the University of Pennsylvania. Dr. Bhide has lectured locally and internationally and published on various topics related to periodontics and surgical implant dentistry. We are very fortunate to have the opportunity to hear him speak tonight. So without further ado, I will hand the virtual microphone to Dr. Bhide.
Well, thank you so much, Alex, for that kind introduction, and to the OAK Seminars Committee for inviting me to speak and kick off the 2021 leg of this lecture series. It really is an honor to have the opportunity to speak to your alma mater. I know that there are people watching from near and afar, and so I really appreciate you taking the time out of your busy days, busy schedules to hear me speak for the next hour, 15 minutes. I trust that you'll enjoy this lecture, and perhaps you'll learn a few pearls, pick up a few pointers, maybe think a little bit differently on something that you're seeing in your own private practice. As Alex mentioned, I'm a homegrown individual. I did my dental schooling in U of T and my specialty training from 2002 to 2005. And one of the reasons why I really enjoy what I do is because of the 2 guys that I had the good fortune of training with. On my left here is Dr. Fayaz Jaffer, and to my immediate left is Dr. Jordan Bender. These guys are my classmates in dental school and classmates in perio. We did our Mount Sinai internship together in between dental school and perio. And I have the privilege of working with both of them in private practice, incidentally. So it's amazing to have that type of camaraderie with the people that you train with. We also belong to a bigger group of people that we call ourselves the Perio Pals. These are really the 2 cohorts, my year and the year behind mine in perio. We're just really fortunate to have each other as friends and colleagues, and our travels have taken us from Toronto all the way to Las Vegas and Chicago and many other places. I'm really grateful to have these people in my life as friends and colleagues. Having said that, we'd really be nowhere without our mentors, and I just want to take a moment to pay tribute to especially these 5 gentlemen who have really influenced and shaped the way that I am as a professional, as a person. I'm grateful to them, and there's not a single day that goes by where I don't think of one lesson that I've been taught by either of these individuals. So if I can be half the mentor to my residents that these individuals were to me, then I'll consider my service worthwhile. We're going to be spending the next hour, 15 minutes talking about the mandibular anterior in specific, particularly with respect to root coverage outcomes treating gingival recession. We're going to review existing classifications of gingival recession and how they're able to predict our treatment outcomes. We will, of course, spend a great deal of time talking about the different treatment options for root coverage in the anterior mandible. And of course, I'd like to keep all my lectures evidence-based. Of course, a lot of what I'm going to speak to you on is about my evolution as a clinician and my experience as a periodontist. But of course, everything that I do is shaped by the evidence and guided by the literature. And last but not least, we're going to talk about what are the factors for optimizing root coverage outcomes in the anterior mandible. We're going to talk a lot today about success and predictability. Success is the ability to achieve a certain result. So in the context of this lecture, for example, complete root coverage of a recession defect would be a successful result. Predictability takes success one step further. Predictability is the ability to have a degree of success a large percentage of the time. So for example, I can do one root coverage procedure and get complete root coverage. But if I'm able to get complete root coverage in, let's say, 80% of my root coverage procedures, then that procedure would be deemed predictable. But perhaps the third important point is what we call replicability. Success and predictability is important, yes, but replicability is also very important. Everything that I show you today in my lecture is something that you can do in your own private practice, particularly for those that are doing some of these procedures that we'll talk about or are surgically inclined. Nothing that I'm doing is superhuman or can't be done by anybody else. And so that's very, very important to keep in mind, because oftentimes we hear lectures and go to courses and try and do these things in our own practice with limited success. I want to take a moment to talk about the definition for gingival recession. And forgive me if this is a bit simple, but you wouldn't believe how many referrals I see for recession when there in fact isn't any recession. The tooth just happens to be long. But in order for us to say that recession has occurred, we need to be able to see displacement of the gingival margin with root exposure. Because if the root isn't exposed, then really we can't cover anything up. So in order for us to say that recession has occurred, we need to be able to see the root surface. And so here we've delineated the CEJ and the amount of recession apical to that. What are the consequences of gingival recession? Not so much in the anterior mandible, but in the anterior maxilla. Aesthetics are always a concern. Recession anywhere in the mouth can lead to hypersensitivity. And as we get older and our salivary flow decreases, root surface caries, of course, as well as non-carious cervical lesions. Areas which have experienced recession are at increased risk of pocket depth development, loss of attachment, which also lead to minimally attached gingiva, and in doing so, decreasing the zone of keratinized tissue as well. Some epidemiologic facts about recession. We know from the work of Kazab and Cohen in 2003 that recession increases with age quite substantially. 50% of individuals from 18 to 64 have at least one recession defect measuring 1 millimeter or greater. Above the age of 65, that population that prevalence changes to about 90%. We know that recession occurs in individuals that have high and low standards of oral hygiene. Patients with low standards of oral hygiene typically have a generalized recession accompanying periodontal disease. Patients with high standards of oral hygiene will typically have localized areas of recession. We know from the work of Chamberlain and Tatakis that even untreated sites with good oral hygiene are more likely to progress over the long term. And of course, the work that we know that we cite often of Kennedy and colleagues and Agudio, we know that sites that have been treated with some form of augmentation do tend to remain stable over time, even if the patient sometimes practices suboptimal oral hygiene. But we're here today because the mandibular incisors and to some degree the canines are also frequently affected. So what is it about the anterior mandible that makes it so special? In my opinion, this is one of the most anatomically unique areas of the entire oral cavity. We see the highest prevalence of malpositioning in the anterior mandible, and oftentimes we have a very thin bony morphotype. So the buccal plate is oftentimes very thin or even dehisced. Not to mention, couple that with the strong pull of the mentalis muscle. We even have prominent frenum pulls here. Here you can see the frenum is pretty much all the way up to the marginal tissue, which also leads to a shallow vestibulum. And then that goes without saying that we have thin marginal tissues. And last but not least, we have gravity working against us. Unlike in the maxilla, where the jaw is fixed and gravity actually works with us, in the anterior mandible, gravity works against us. And this is why root coverage outcomes typically are poorer overall in the mandible than in the maxilla. So this is a very common presentation that as a periodontist I see in my practice almost on a daily basis. We see areas of localized recessions, we see areas of multiple adjacent gingival recessions. Whatever the case, in this particular area, these patients would have a couple of things in common. Almost all of them have thin periodontal phenotype, and almost all of them have had orthodontic treatment to some degree. And even if their teeth look in perfect alignment, if you look at them from occlusal views, you can see that there is some slight aberrations of root positioning that can lead to dramatic changes in the gum tissue, in the position of the gingival margin. A really nice study from Renkema and colleagues in 2013 looked at the incidence of recession in individuals that were treated with orthodontic treatment, and they followed them for about 6 years. And what they found was that 35% of all of the teeth treated experienced gingival recession, which persisted for about 6 years post-ortho. In relation to the untreated patients, the ratio of teeth that experienced recession versus not was about 2 to 1. If you were to focus in on the mandibular incisors only, the ratio now becomes 8 to 1. So orthodontic treatment does substantially influence the possibility of developing recession. Now, the literature is divided on whether or not orthodontic treatment causes recession. Causality is still debatable, but there's certainly an association between orthodontic treatment and gingival recession. And so Renkema concluded that orthodontic treatment and or the retention phase may be risk factors, and that the mandibular incisors are the most vulnerable teeth in the mouth. Most of us are familiar with the Miller classification of gingival recession. And for those of us that aren't, we'll just review this quickly. Preston Miller is a very respected periodontist. In 1985, he came up with this classification that not only classifies recession defects into 4 different categories, but based on what classification you assign to a particular recession defect, this classification is supposed to be predictive of the root coverage outcome. So briefly, class 1 and class 2 Miller recessions are ones that theoretically can expect complete root coverage or 100% root coverage. The only difference between class 1 and class 2 is that the recession in class 2 extends beyond or apical to the mucogingival junction, but the intraproximal bone and soft tissue is otherwise intact. A class 3 recession is when you start seeing loss of intraproximal bone and soft tissue, or there's some degree of malpositioning. And a class 4, which is not really amenable to root coverage, is typically the type of situation you'd see when there's periodontal disease concurrently with the recession. For class 3, I'll just go back, partial root coverage can be expected. This classification has essentially served us for the past 35 years, and I would say reasonably well. But there are a number of drawbacks to this classification, as highlighted by Pini Prado in this excellent editorial, Journal of Clinical Periodontology in 2011. The Miller classification is essentially one man's classification. There's really no reliability and validity to it. We're essentially using Miller's own experience, and he's a very talented surgeon. We're using his own experience and prognosticating for our own patients. There was no real scientific testing of Miller's classification except for in the paper that Miller published. So this editorial actually led to a fellow by the name of Francesco Cairo doing a formal study and coming up with his own classification called the Cairo Classification, which has three parts: the RT1, RT2, and RT3. And the study that this classification came out of was published in 2011. And what they looked at was two things. They looked at reliability and validity. So reliability was, okay, let's show three periodontists that are involved in the study a whole bunch of recession defects from all over the mouth. I think someone's got their mic on. And let's see how much inter-examiner agreement there is. This classification was based on primarily intraproximal clinical attachment levels. And what they found in the reliability study was that there was really good, really high inter-examiner agreement. And so this was a reliable classification system. Now, could this classification system be prognostic or predictive of root coverage outcomes? So the second part of their study, which we'll look at in a few slides, tells how prognostic it is. But let's go through these categories first. An RT1 recession is recession that has no loss of intraproximal attachment. And the way to really tell this is whether your intraproximal CEJ is detectable or not. So if you cannot detect your intraproximal CEJ with an explorer or a probe, we can classify this as an RT1 recession. An RT2 recession is when you start seeing some loss of intraproximal attachment. So either the CEJ is visible, but the attachment loss intraproximally, or the attachment level, is still less than the attachment loss or level on the buccal aspect. An RT3 recession is when you start getting more attachment loss intraproximally than you have on the buccal aspect. So it's gingival recession that's associated with loss of intraproximal attachment, but the intraproximal attachment loss is greater than the buccal attachment loss. So now into the validity study, what Cairo and his colleagues did was they looked to see in various scenarios how predictive this classification was in determining root coverage. And for RT1 recessions, what they found was that 75, almost 3/4 of their sites had complete root coverage versus an RT2 site, which maybe only 1/4 of the time achieved complete root coverage. And so it was pretty predictable for an RT1 situation. As far as mean root coverages go, we're looking at almost 85 to 90% in terms of mean defect coverage for an RT1 recession, and about 66, 67% for an RT2 recession defect. So they concluded that the evaluation of the intraproximal clinical attachment level can be used to classify gingival recession defects, and more importantly, to predict clinical outcomes. I mean, what better than a classification system that can actually give you some idea of what result to expect? It's a great way to communicate with referring dentists. It's a great way to set up patient expectations as well. Now, it doesn't always match up, but for the most part, Miller class 1 and class 2 is somewhat congruent with an RT1. A class 3 Miller is congruent with an RT2, and a class 4 Miller is congruent with an RT3 Cairo classification. But sometimes you can have a Miller class 3 with an RT1, for example, right? So it's not an exact science, but for the most part, they line up fairly well. So let's talk about this case here, because this case is really pivotal to this lecture. This patient came in to see me with about 3 to 4 millimeters of recession on the buccal of tooth number 4-1. We can see that the tissues look otherwise healthy, but they're thin. There's also a prominent frenum pull here as well. The patient's chief complaint was that of progressive recession as well as hypersensitivity of the root surface. She was about 45 years old, healthy, wanted to have something done about it. So in this case, when we determine our problem list, we've already talked about recession, frenal proximity, thin marginal tissues. We also have black triangles, and there's really not a whole lot we can do about those predictably. There was evidence of progression, and the patient also had sensitivity. We diagnosed this as being a Miller class 3 or an RT2 recession defect, and the patient also had a thin gingival phenotype. So the objectives in a case like this is that, number one, we want to stop this recession from progressing. We also want to get coverage of the root surface, because if we're able to do so, then we can also decrease or even eliminate the sensitivity. And at the same time, we also want to eliminate the influence of the frenum pole, because that is definitely an etiologic factor for recessions like this. Last but not least, we also want to modify the periodontal phenotype. This is a very, very hot topic right now. And phenotype modification involves increasing the tissue thickness or volume, and in particular, increasing the zone of keratinized tissue. Whether keratinized tissue is important or not, again, it's debatable in the literature. It's one of those things where I think the more people you talk to, I think there'd be some consensus that it is important, and just because studies haven't shown it to be unequivocally necessary, it doesn't mean that it isn't. So here's an illustration of a case where a patient came in with very minimal recession on their canine, and the tissues look nice and healthy, but when you probe into the sulcus, you can see that show through of the probe. And so this tissue would be deemed to be fairly thin. The work of Joseph Kahn and colleagues came up with a number of about 1.1 millimeters. That's how thick the marginal tissue needs to be for you not to be able to see the probe. And we know from the literature that thin marginal tissues are quite susceptible over the long term in developing recession, because the attachment is just not as robust and resilient, and it represents a gateway for plaque buildup and ingressive bacteria. In a review by Chambron and Tatakis, I talked about this briefly earlier, where they looked at long-term outcomes of untreated buccal gingival recessions. They noted that pre-existing keratinized tissue definitely influences the development and progression of the gingival recession, and that marginal keratinized tissue quality needs to be considered, especially when establishing restorative treatment plans. I was talking to a colleague of mine today where the patient had full mouth reconstruction and shortly thereafter started developing recessions. And so before the patient has these done, it's nice to have that discussion with the patient. And if we need to augment, better to augment before the restorations than afterwards. So treatment options, getting back to this original case here, would be subepithelial connective tissue grafting, or CTG for short, or a substitute, like a dermal matrix. And typically the flap approaches that we employ are either envelope flap, a coronally advanced flap, or a tunnel approach. We can also use a free gingival graft or an epithelialized palatal graft, same thing. Or there's no treatment, which is also an option. But the patient wasn't there to see me because she didn't want any treatment. She wanted to have this addressed definitively. Now, my instincts would tell me that I would want to treat this case with a free gingival graft. But like normal human beings, I'm also susceptible to being influenced by my peers. And so I went with a connective tissue graft in a tunnel approach. And I did this because, from talking to my colleagues, you hear these statements: I tunnel everything, I use dermal matrix everywhere, I don't think I've done an FGG in over 10 years, et cetera, et cetera. And it makes you think, hey, I want to do an FGG, but, am I doing something wrong? Am I not doing the right thing for the patient? Should I be doing a tunnel with a connective tissue graft because everybody else is? And sometimes we don't realize how influenced we are by what we hear from our colleagues. And we also sometimes realize that maybe this isn't always all informed by the evidence in all cases. So I persisted and I did a connective tissue graft with a tunnel approach. And this is the result that I ended up with. And the only way that you can tell that this is a different photo is if you can see this little hue here of blue. And that was a polypropylene suture that got embedded in the tissue that we just left in there. And so I was pretty disappointed with this. I mean, it's sort of what I consider a non-result. I really didn't do much for the patient. There's really no way that I can even put a positive spin on this result. And this was at about 6 months. So when I look at the original preoperative photo in comparison with the 6-month postoperative, really not much is done. If I really want to be trying to look for something, I could say maybe I gained about a 0.5 millimeter of root coverage. But as far as the patient's concerned, nothing really was done. And this is not the way that I want to send my patients back to my referring dentist looking like nothing was done, or trying to convince the patient that something was done when I know that she knows that really nothing was done to her liking. And this really made me reflect. I mean, this is one case, but this was probably the straw that broke the camel's back, because I started reflecting on my cases for treatment of gingival recession in the anterior mandible, and started realizing that I was probably disappointed more times than not with the outcome. And I wasn't having that issue elsewhere in the mouth, particularly in the maxilla. And a couple of days later, I saw this patient, and I'd done a free gingival graft for this patient about 6 years prior. And I remembered his name because it was a very unique name. He was an Eastern European fellow, and just his name had stuck with me. And the one thing that I always do is I take a preoperative photograph for every recession case, or most recession cases. And I remember that I'd taken a photograph of this gentleman, or I assumed that I had. So I took a picture of his free gingival graft. And as soon as I went home that day, I started looking through my hard drives to try and find the preoperative photograph, because I just couldn't remember 6 years ago how extensive that recession was. So I find the preoperative photograph, and this is what it looked like. So in a case like this, you can see that the patient has black triangle, patient has wide and deep recession, thin marginal tissues, strong frenum pull. And so we diagnose this as Miller class 3 RT2 recession. So this is the type of situation where we're expecting partial root coverage at best, given the fact that we've got very, very thin papilla here, intraproximal attachment loss. I'm not really expecting a whole lot. So I wasn't even really going for root coverage in this case. We did a free gingival graft. And if you look at the position of the free gingival graft here, very little attempt has been made to obtain root coverage. I didn't see the patient back after this. The patient had actually come back to see me again 6 years later for a recession affecting another area in his mouth. But I never saw this patient back for a post-operative visit until he came back. And then this is what I see at 6 years. So when I look at where I positioned the graft, initially, where no attempt really was made for root coverage, and 6 years later, there's almost complete root coverage, it makes me wonder. It actually confirmed that creeping attachment is a real phenomenon. Creeping attachment is the coronal migration of the gingival margin following grafting procedures, particularly free gingival grafts. It's about 1 millimeter, and most of it occurs in the first 6 months to a year after grafting. So I would say that I was pleasantly surprised, kind of blown away actually, by this result, and not to mention that I'd never seen this guy after his surgical visit. Then about a couple of days later, I saw another patient that I'd seen earlier that had recession from canine to canine. You can see how thin the tissues are here. You can see where the recession is. I've marked it in black where the CEJ is. We did a free gingival graft for this patient, and the 3-year post-operative patient comes back with nice, thick, sustained health of her tissues. We've also managed to get almost close to complete root coverage on most of these teeth, and this is the result at 3 years. And when I look at the preoperative side by side with the 3-year postoperative, at 3 years, I'm blown away. So now I've seen a failed case of a CTG and 2 uber successful cases with an FGG in the anterior mandible for root coverage. A week later, another patient that I treated with an FGG came back for her 2-year postoperative visit, and we didn't obtain complete root coverage for this span from 3.2 to 4.2, but considering that there's close to moderate bone loss on the central incisors or across this entire span, again, this is a pretty impressive result, and I'm sure that there's been creeping attachment over this 2-year period. So this is really kind of my struggle moment, right? Like this is when Luke Skywalker finds out in Star Wars, The Empire Strikes Back, that Darth Vader is his father. He's forced to face the reality of this situation. And I include this because I'm a hardcore Star Wars fan, and every single lecture of mine features some reference to Star Wars. But this is really probably what I looked like on that day too, when I saw that third patient with the really successful free gingival graft. So rather than getting down about it, I said, okay, let's go to the literature. Let's see, like, why am I not enjoying the same level of success with connective tissue grafts in the anterior mandible? Like, what could I be doing that's maybe a little bit different, or what am I not doing? And so I found a whole bunch of review articles, systematic reviews, meta-analyses over the last 10, 12 years, looking at connective tissue grafts and treatment of gingival recessions. And what all of these meta-analyses and systematic reviews seem to point out, pardon me, is that coronally advanced flap plus a connective tissue graft is the gold standard for root coverage. This is what we talk amongst ourselves with our colleagues. This is what we tell our patients, that connective tissue grafting is the gold standard, particularly with respect to root coverage and increase in keratinized tissue width. But then I came across this paper by Tatakis and colleagues. Once again, Tatakis is a very, very prominent guy from 2015. It was in a supplement of the Journal of Periodontology. And they looked at a whole bunch of studies regarding soft tissue root coverage procedures and came up with a bunch of conclusions and recommendations. And what stood out to me was the fact that the majority of the evidence that we look at is derived from maxillary canine and premolar teeth. And most studies we look at are for Miller class 1 and class 2 defects. And these are the most successful because they're the most amenable to root coverage. And the canine premolar region is also very amenable for surgical manipulation because you've got good tissue, usually, you've got good vestibular depth. They also mentioned that evidence on site-specific factors is limited and that we need more research on comparing various modalities of treatment. So this paper really is something that influenced me greatly and sort of made me realize, okay, you know what, maybe a connective tissue graft is not always the panacea for recessions everywhere in the mouth. To further illustrate this, in articles published by Zucchelli and his group in 2018, where they looked at the influence of tooth location on coronally advanced flap procedures for root coverage, they looked at about 18 articles with close to 400 recession defects. And when you look at the frequency table of the sites that they looked at, when you look at the maxillary canine and first premolar, it comprises over half of their total data set, whereas mandibular central and lateral teeth only have about 17%, almost 3 times difference in terms of the number of teeth. If you add the mandibular canines in there, maybe it increases to about 20, but there's still about a 2.5 to 3-fold difference. And so our results are quite heavily skewed. The paper that I just talked about was looking at single recessions. When we look at multiple adjacent gingival recessions, we can see a similar trend in that when you look at the site specificity, there's very few studies actually looking at the mandibular anterior segment, particularly for coronally advanced flap procedures. And when you look at coronally advanced flap plus connective tissue grafting, you'll notice here that the complete root coverage is only about 60%. Now, of course, Zucchelli is a very talented clinician. His results may not be necessarily representative of the average person's, but nonetheless, this does illustrate that the outcomes in the anterior mandible are a bit inferior to that of the rest of the mouth. So I ask again, is CTG, connective tissue grafting, the unequivocal gold standard for root coverage procedures? And the answer to that question, I would say, is no, because the data is heavily skewed towards the results obtained from incisors, canines, and premolars in the maxilla. And there's actually very little data looking specifically at root coverage procedures in the mandibular anterior region, specifically incisors. So let's talk about the free gingival graft. This was one of the earliest methods of gingival augmentation, talked about by Bjorn and King and Pennell in the early 60s. It involves taking an epithelialized graft from the palate and transplanting it in the area where the gum is deficient. And its primary use was for increasing the width of keratinized tissue, either submarginally or at the gingival margin. In a review by Dr. David Kim and Rodrigo Neva in 2015, they did say that it was the most predictable method of augmenting tissue in non-root coverage situations. Just a plug, Dr. Rodrigo Neva will be speaking to us in a couple of weeks on bone grafting. So please do register for his lecture when that becomes available. So let's take you through the submarginal technique. So here's a patient that has a Miller class 3 or RT3 recession, and you can see there's significant crowding, there's severe recession, thin marginal gingiva. This is really not a situation that's amenable to root coverage. So we start by making an incision at the mucogingival junction. Remember, coronal to the mucogingival junction, we have our keratinized tissue. Apical to that, we have our loose alveolar mucosa. So the purpose of doing a graft in this case is to augment the zone of keratinized tissue. So we make our incision at the mucogingival junction. We prepare our split thickness recipient bed. And then we take our palatal graft that's epithelialized and secure this in place using a combination of interrupted sutures and periosteal compression sutures. And there's no procedure really more predictable, or very few that are more predictable than this procedure, the free gingival graft for augmenting the zone of keratinized tissue. Of course, we have to be mindful of the patient's palate and how we're going to manage that. But at 1 year, we can see a nice blending of the graft. We know that the recession's not going to progress. And interestingly, the patient drinks a lot of tea or coffee, and it's actually sort of highlighted where the CEJ is quite nicely. So we can see that we don't have really much root coverage, if any, but we have a nice thick band now of keratinized tissue, which is going to provide good support and health for these teeth moving forward. Now, what about for root coverage? Well, Sullivan and Atkins were really the first in the late 60s to suggest that free gingival grafting could be used for root coverage. They came up with one of the first classifications. And then, of course, Preston Miller, who we talked about earlier, really was the champion for free gingival grafts for root coverage, not just in the anterior mandible, but anywhere in the mouth. But a lot of his work was focused in the anterior mandible. And we've all seen these patients in our practice. Some of them who are much older have had grafts done back in even the 60s and 70s that have lasted the test of time. The knock against free gingival grafting that most people will talk about are the fact that they feel that there's insufficient blood supply. There's a single source of blood supply, which is from the periosteum of the recipient site, and we don't get any blood supply from these avascular root surfaces, and of course, that will in turn diminish the predictability, or maybe it will, maybe it won't. I hope to impress upon you that maybe it's not the case and that there is more predictability than we think. So here we've prepared our recipient bed, and you can see how much recession this patient has even after the recipient site's been prepared. We once again place our graft in place to try and cover up the root surfaces. But again, because of the insufficient blood supply and predictability, perhaps, we achieved a result where root coverage really wasn't significant, but we did increase the zone of keratinized tissue by a couple of millimeters. Some people will argue that the aesthetics of a free gingival graft aren't the best. I agree, it's not. But in the anterior mandible, where aesthetics is not really a huge concern, I say, does it really matter? And then, of course, there's post-operative considerations, namely management of the palate. So this is usually left as an open wound, and patients will oftentimes complain about pain and delayed bleeding after the fact. But again, even then, is pain that much more substantial than what we see with a connective tissue graft harvest? Well, a couple of studies done by Zucchelli tried to answer this question, and what they found. Now, let me just give you a little bit of background here. Zucchelli has a very specific technique where he does connective tissue graft by essentially harvesting the equivalent of a free gingival graft and deepithelializing it to obtain the connective tissue. And so the results from the study really apply to any free gingival graft procedure when you think about it. And what they found was that there really was no difference in a deepithelialized harvest versus a conventional single door or trapdoor approach for connective tissue graft harvest in terms of analgesic consumption, postoperative discomfort, and even bleeding. And the most important factors really that determine whether patients have pain or not is the graft height and thickness. Typically, if you have a graft height that's more than 4 millimeters, that's associated with more pain. And the thicker the graft means that there's less residual soft tissue covering the palatal bone. That's when patients will experience maybe a little bit more pain. But this argument that, I don't do free gingival grafts because the patients have more pain is sort of not always holding much water. And there's also ways to manage the palate, which I do very regularly. Copac, believe it or not, one of the simplest things to do. One of the most ubiquitous periodontal dressings, I can put this over a recipient site, and even if it falls off after a couple of days, it's fine. It's gotten the patient past that really initial part where they're going to complain of the most pain and discomfort. This here on the left side is a material that I had the pleasure of using for a few months that it was available in Canada. It's essentially a polymeric bandage, if you will, that slow releases vitamin E, which is critical for healing. And as long as the palate is covered, I think the patients experience significantly less pain than if we leave it exposed. But even if we left it exposed, it's not super significant. So, the paper by Tatakis talked about head-to-head studies. So, what about free gingival graft versus a connective tissue graft in the anterior mandible? And believe it or not, in the entire canon of periodontics literature, there are only 2 studies that talk about free gingival graft versus connective tissue graft head-to-head. One of these studies is by Janke and colleagues that was done in the early 90s, where they had 10 patients with paired defects that were separated by about 4 teeth, and they were randomly assigned with a coin toss. And what they found was that the mean root coverage, of course, was greater with a CTG versus an FGG, almost twice as predictable or twice as successful. And even predictability, they were able to get complete root coverage with 5 out of 9 sites with a connective tissue graft and 1 out of 9 with a free gingival graft. So 5 times the predictability. And so, of course, they concluded that connective tissue grafting provides better root coverage and that both procedures resulted in increased keratinized tissue, improved probing attachment levels. And if I was just to read the study at face value, of course, I would think that connective tissue graft is naturally superior than a free gingival graft. But when I look at the numbers, when I look at the breakdown of what they treated, I want you to focus on the left-hand side where they break down all the sites they treated with the free gingival graft. So out of 9 sites, 3 were in the anterior mandible, all canine teeth. If you look at the mean root coverage for these canine teeth, it's about 75%. And this is much higher than if you were to look at all the other teeth. These include maxillary teeth and molar mandibular teeth, where the root coverage success is much, much lower. So the free gingival graft was pretty successful in the anterior mandible. Connective tissue grafts were more successful, and in the 1 canine tooth, they managed to get 100% root coverage, but they also managed to get 100% root coverage on the canine tooth with a free gingival graft. So really, I'm not sure that this study really proves anything that CTG is superior to the FGG in the anterior mandible. Maybe in other areas of the mouth, I can certainly see the argument for that, but not in the anterior mandible. The second study by Paulo Antonio and colleagues in 1997, they again did a head-to-head study, free gingival graft versus connective tissue grafting, and very similar to the study that I just showed you by Janke and colleagues, they found that there was significantly more success with a connective tissue graft at 6 months for root coverage than for a free gingival graft. And again, almost 5 times the predictability for complete root coverage with a connective tissue graft versus a free gingival graft. And once again, connective tissue grafts are better than free gingival grafts for root coverage, and that both procedures increase the zone of keratinized tissue. Now, this study did not include data on which teeth were treated with a free gingival graft or which teeth were treated with a connective tissue graft, or how many patients completed the follow-up at 5 years. And interestingly enough, when you actually look at the paper and read it carefully, the representative pictures that they showed for connective tissue grafts were for the maxillary canine and for free gingival grafts in the anterior mandible. So again, why are they showing a free gingival graft in the anterior mandible? Because it probably worked the best in the anterior mandible for them. So little things like this where you have to have a good critical eye of the literature, because if you just look at the abstract or go to the results section, you don't capture the essence of this. And sometimes you'll come up with things which sort of refute what's being said in the paper. So now, again, back to this case, back to this saga. We decided to treat this with a free gingival graft. And so I prepared my recipient site, harvested the free gingival graft from the palate and secured it. And this is usually my go-to. We prepare a nice recipient bed, take a free gingival graft that extends at least 2 to 3 millimeters lateral to where the recession is, secure it with interrupted 5-0 chromic gut sutures, and then a periosteal cross mattress compression suture. And then at 6 months, we see a really, really nice result here with nice blending of the graft, some root coverage, increase in the zone of keratinized tissue as well. And at 1 year, I think we even see a little bit of creeping attachment here as well, and which is evident when you look at the 6 months and the 1 year side by side. And so we have gotten a little bit of creeping attachment in that 6 months to 1 year. And when you look at the original pre-op versus the second pre-op, or the post-op that really wasn't, and then the 1 year result, we can see that now we've gotten some substantial root coverage in again, an RT2 or Miller class 3 situation. And we've also managed to increase the zone of keratinized tissue, which will for sure serve this patient well in the long term. Here's another case where we diagnose as a Miller class 3 because there's loss of intraproximal tissue, and an RT2 recession because we can see the CEJ present. Here, there's almost no keratinized tissue. We have a shallow vestibule. We have thin marginal tissues that are inflamed. We prepare our recipient site, once again, split thickness, and I want to have at least 3 millimeters of horizontal incisions here that I can get good blood supply to the graft from these papilla. We prepare our recipient site. We take our graft from the palate, interrupted sutures along the periphery, 5-0 chromic gut, and a periosteal compression suture to get good horizontal adaptation of this graft. Simple. I mean, this is not anything complex. I mean, I think that like anything, the more you do it, the more success you see. But there's no suture removal here, and even the results are very low maintenance. And at 4 weeks, the beauty about these grafts is that the short-term healing is very indicative of how stable this result is going to be in the long term. So at 4 weeks, we can see that this graft is taken. We can still see a little bit of a lip between the graft, or it looks disjointed between the graft and the intraproximal papilla. But all that gets nice and smoothed out by about the 1 year mark. And I've not touched this graft. This is the natural healing progression for this graft. And when we look at the preoperative versus the 1 year postoperative, not only have we gotten complete root coverage, but we've also changed the phenotype of the gingiva, eliminated the frenum pull, eliminated the patient sensitivity, and have positioned this tooth for a nice, long, healthy life. Here's a case where we have high frenum pull, thin marginal tissues, minimal recession. And you might be wondering, well, why is he showing us this case? Because there's really not a whole lot going on here. I wish I had a photo that showed you how thin this tissue was when I was probing it. You can almost get an idea here with how blanched this tissue is. Nonetheless, we diagnose this as Miller class 3 because of the malposition, but because there's no interproximal attachment loss, we call this an RT1. So this is where I say that there's a discrepancy. For Miller class 3, you're not expecting complete root coverage, but for an RT1, a complete root coverage result is predictable about 75, 76% of the time. So we did a free gingival graft. We included the 3-1 and the 4-1. And what I want you to note here is the hidden recession. So if I go back, you can see that there's somewhat minimal recession on the 3-1, but quite a significant amount of hidden recession on 3-1 once we prepare our recipient site. We take our free gingival graft from the palate and secure it. Now, in this case, I had to use monofilament sutures because if you notice here, what happened is that during my graft harvest, I got a bit overconfident. And as a result, I sort of sliced this piece accidentally. And so I had to actually suture these two segments of the graft together. So I was a bit nervous about whether the graft would take or not. But much to my pleasant surprise, the graft took. And not only did it take, but I think we've also managed to get root coverage. The graft looks nice in terms of its blend, in terms of its quality. We've eliminated the influence of the frenum, established a deeper vestibulum depth. And again, this is a healthy situation, which is going to benefit the patient in the long term. How about for canine teeth? I've only really shown you incisors at this point. This 18-year-old gentleman came to see me for treatment of recession. And when you look at the marginal tissues, it's an absolute inflammatory mess that's going on here. Not only does he have recession, but he has significant inflammation of the marginal tissue. We did try to reduce this inflammation by topical chlorhexidine. Patient came in for hygiene as well, but really nothing we could do to quell this inflammation. He also has minimally attached gingiva, shallow vestibule. So we did a free gingival graft, because doing a connective tissue graft here would not be easy, because this tissue is so friable that I just don't even know that you'd even be able to elevate your flap to prepare a recipient site. So we're almost doing like an addition by subtraction here, where we remove this entire collar of inflamed epithelium, prepare our recipient bed, secure our free gingival graft, and at 6 months, we can see that we've gotten complete root coverage. We have nice zone of keratinized tissue. And despite the fact that there's still inflammation, as the patient could still improve their oral hygiene, I'm not really worried about this progressing or getting worse. Now, again, aesthetically, is it the best? No, but it's the anterior mandible. Patient's happy. Patient doesn't have sensitivity anymore. Bleeding gums. I'm happy because as a clinician, I've been able to achieve what I wanted to achieve. And I know that even if the patient disappears for the next 5 years, this graft is just going to continue probably looking better over that time. So speaking of aesthetics, Cordellini's group in Italy in 2012 published a paper where they did a modification of the free gingival graft, where they partly, where they de-epithelialized the region that was apical to the mucogingival junction. So they'd line up their graft in the recipient site, and wherever the mucogingival junction was, apical to that point, they would de-epithelialize the graft and leave this exposed connective tissue, with the thinking that the graft would blend better with the mucogingival junction, because you probably remember some cases that I've shown you where there's a bit of a discrepancy. Now, in this case, I mean, the aesthetics are pretty good. I mean, I don't know if they're any better than if we were just to leave this epithelium intact, but nonetheless, they showed in their papers substantial root coverage using a free gingival graft in the anterior mandible. Let's look at a case where we've got multiple adjacent gingival recessions. This young lady, she's about 31 years old when she came to me. You can see how thin her keratinized tissue is here, and you can see the vestibulum depth is pretty shallow. There's a prominent frenum here, a loss of interproximal tissue. So I diagnosed this as a Miller class 3 RT2 recession. Now, two things should stand out, the 3-2 and the 3-3. You can tell even from this buccal shot that the 3-2 and the 3-3, the roots are somewhat outside the envelope of the arch. And this is certainly going to play a role in the result that we obtain. So in a case like this, where I think, can I do a connective tissue graft versus a free gingival graft? I almost always do a free gingival graft in a case like this, because I'm not just going for root coverage in one shot. I'd like to think that I can build up the keratinized tissue, change the phenotype, and if need be, I can always go back and then get root coverage later, versus doing a connective tissue graft and putting a lot of tension on the vestibule. And lateral views of this will show you how shallow that vestibule is and how deep that recession really is. So we prepare our recipient site, and we can see how prominent these roots are for especially the 3-3 and the 3-2. You can see that they're almost popping out of the alveolus, whereas from the 4-3 to the 3-1, yes, the recession is somewhat moderate, but they still look like they're relatively within the housing of bone. So we prepare our recipient site and harvest our free gingival graft. Now, this patient has a shallow palate or narrow palate, and so it was difficult for me to get one continuous harvest for the entire span from 3-3 to 4-3. Keep in mind that the span is almost 40 to 45 millimeters long. So I went to both sides of the palate, harvested the epithelialized graft, and then sutured these two segments together with monofilament sutures to create one long piece of graft tissue, which we then secured to the recipient site using a combination of polypropylene sutures and then 5-0 chromic gut for the periosteal sling sutures for good horizontal adaptation. So I'm trying here for complete root coverage because I figured that why not? At the very least, I'll get some root coverage, but let's go for as much root coverage as possible. And you'll notice that the graft length is also about 6 millimeters or so, because I want it to be at least a couple of millimeters beyond the extent of the recession to sort of maximize how much I can cover that. Ironically, these type of broad grafts work somewhat better than a single graft, because you have more sources of blood supply to draw from than with a single site. And at 6 months, I just saw this patient today, this morning, so I was frantically rushing to get this into my presentation. At 6 months, we can see that we have a nice zone of keratinized gingiva. We've eliminated the influence of the frenum pull, and we've even obtained root coverage, more so from the 4-3 to the 3-1 than the 3-2 and the 3-3. But I would say that all things considered, when you look at the pre-op and the 6-month post-op, if I was to draw this line to denote where all the CEJs are, we can see that in relation to the pre-op, we've actually managed to get some pretty decent root coverage for at least these 4 teeth, and even reasonable root coverage, I guess as much as expected for the 3-2 and 3-3. And now the next step would be to do a coronally advanced flap procedure to try and get more root coverage, particularly for these 2 teeth. And this approach has been described in the literature by Bernie Moulin and colleagues in the mid-70s. But at the very least, I know that we don't have to worry anymore. The patient also feels much more reassured that her teeth aren't going to fall out, and that she's not at risk now of progressive recession. If we look at the lateral views, we can see the nice infrastructure of gum tissue that we've built up here, increased the vestibular depth as well. And you'll find that oftentimes the patients may not even want to go ahead with the secondary procedure because they're pretty happy with the first one. So when we look at what makes a free gingival graft successful, there are a number of factors. These were described in detail by Miller in 1987, Cordellini in 2012. And I can also tell you from my own personal experience that a healthy non-smoking patient is more ideal than a smoking patient, because already the blood supply is not as great as it is for a connective tissue graft. And then smoking on top of that will compromise that further. We want to make sure that we have a proper diagnosis of a defect and set realistic expectations for the patient. Do I tell every patient with an RT1 or a Miller class 1 or 2 recession that they're going to get complete root coverage? Absolutely not, because even if they get a 1/4 millimeter showing, it's a failure in their eyes. So, what I do tell them though is that certain situations are more amenable to getting maximum root coverage. Thickness of the graft matters, particularly for root coverage and free gingival grafts. You want a graft that's about 1.5 to 1.8 millimeters thick. We want to prepare the recipient site adequately. So so oftentimes I'll find myself extending my graft site just to draw in more blood supply and nourishment to the graft, because that will help with root coverage. Immobilization of the graft with interrupted sutures, with horizontal stabilizing sutures is absolutely critical. You want good intimate adaptation between the graft and its single source of blood supply. And then last but not least, there's the interdental papilla dimension. Many years ago when I was a resident, I had the pleasure of hearing Dr. Miller, Preston Miller, talk at an Ontario Society of Periodontists meeting. And he just nonchalantly mentioned that the interdental papilla dimension horizontally should be about 3 millimeters for you to get root coverage up until that point. Now, this number has actually never been validated in the literature, but when I look at my own cases anecdotally, I can see that 3 millimeters is quite predictive of where I'd get root coverage to. So that's why I extend those horizontal incisions at least about 3 millimeters. The work of Zucchelli and colleagues with connective tissue grafting with their coronally advanced flap technique, they also do a horizontal incision about 3 millimeters in the interproximal papilla. So there is some importance, and maybe one day there'll be a study that comes out that shows that. So I looked at my own results from private practice, and right now I'm writing this case up, this study up with Dr. Rodrigo Neva to submit for publication, where we looked at free gingival grafting for root coverage in the anterior mandible. We looked at sites that had minimum 6 months of follow-up, and up to this point, we're at about 65 recession defects that have matched, that have made the 6-month criteria. We're hoping that we'll get at least 80 or 100 over the next couple of months to be able to really make our analysis robust. Most of our patients are healthy, non-smoking, and the mean initial depth is about 3 millimeters. And what we found so far, which is pretty interesting, is that the mean root coverage for RT1 recession defects is about 80%, but sites with complete root coverage is about 73%. And for an RT2, as expected, it's much lower than that. But what's interesting about this is when I look at Cairo's validity study, it's quite similar in terms of the mean root coverage for RT1 and for complete root coverage. So interestingly, Cairo's study didn't really look at free gingival grafts as part of their validity study. It was mostly based on coronally advanced flap procedures and connective tissue grafting, and the majority of their sites were actually, surprise, surprise, maxillary canine, incisor, and premolar sites. So what's interesting is that my private practice results show that free gingival graft in mandibular anterior can actually be quite predictable and successful for root coverage, but it's also, I guess, validated by the Cairo classification and vice versa. So stay tuned for this. Now, I don't want to joke about this because what's going on south of the border really pains me. But 2.5 years ago, when I joined social media, I started this hashtag, Make FGGs Great Again, as a tongue-in-cheek joke, I guess. But to my surprise, this movement, if you will, caught on with some pretty good steam, and a number of people that I've connected with over the past couple of years have led me to realize that more people believe in free gingival grafts more than I thought. So if you're on social media, you can type in this hashtag and you'll see some really nice cases by people from all around the world looking at FGGs for root coverage. But let's talk a little bit about evolution, right? Because I think this is very important in any clinician's career, is the evolution, like what has led someone to do what they do. And certainly I hope that I've been able to enlighten you with my story of why I went back to free gingival grafting in the anterior mandible. And it was because of a string of unsuccessful or suboptimal results with connective tissue grafting and coronally advanced flap procedures. But yet I still see people that have success with these procedures. So I think to myself, I've had my fun with the free gingival graft. I've kind of gotten it out of my system, if you will. I love it. It still is a workhorse in my practice, but maybe I should be exploring connective tissue grafting as well, and see if I could come up with something that is successful and predictable, similar to what I'm seeing with free gingival grafting. So what about connective tissue grafting for root coverage in the anterior mandible? So in the literature, there, again, aren't that many studies that actually look specifically at the anterior mandible. And these are, I think, most of the studies that I could find, certainly not exhaustive, but ones from peer-reviewed journals that looked at various techniques, all involving connective tissue grafting for the most part, looking at Miller class 1, Miller class 2, Miller class 3, RT1, RT2, recessions, coming up with mean defect coverage and predictability data. We're going to talk about 3 of these, the 3 that have really impacted me personally and as a clinician. I'm also in the process right now of doing a systematic review and meta-analysis for the anterior mandible in particular. And so far, what I can tell you is that for Miller class 1 and class 2, we can see about an 85% mean defect coverage and 70% complete root coverage in the anterior mandible. And for Miller class 3, that mean defect coverage decreases, and so does the complete root coverage percentage as well. So again, this is some pretty exciting stuff that I'm happy to be involved with, and stay tuned for that. So the first study I want to talk about is one by Randall Harris, again, a very skilled clinician, not practicing anymore, but came up with this paper where he looked at comparing 3 techniques for root coverage for recession mandibular incisors. He had 3 groups: coronally advanced flap with a connective tissue graft, a double papilla technique with a connective tissue graft, and a lateral tunnel with a connective tissue graft. We had 21 patients per group, and this was done in private practice. So for me, as a private practitioner, this makes me a little bit more excited because it's not under the same control as a university study. The only downfall to this study really was that it's a 3-month study. Looked only at Miller class 1 and class 2, but recessions that were more than 2 millimeters or greater. And what he found was that regardless of the group, there was really no difference in root coverage outcomes when the recession was very shallow, like less than 3 millimeters. But when recessions were deeper, like 3 millimeters or more, the double papilla technique or the tunnel, lateral position pedicle groups were more superior for these deeper recessions. And one thing I can tell you from my experience is that oftentimes recession in the anterior mandible is not typically shallow. It's typically at least 3 to 4 millimeters or greater. So he concluded that when you're looking at these defects that are greater than 3 millimeters, or even multiple adjacent defects, consider a double papilla approach or a tunnel approach. And I want to illustrate a case that shows a double papilla. There's a beautiful case that was sent to me by one of my good friends and periodontist colleagues in North Carolina, Dr. John Kim. So here we have a recession, which is quite significant. It's quite deep, but we have nice thick tissue peripheral to the recession. So what we do is we prepare essentially 2 pedicles of tissue that we can then bring together to completely cover the graft. So we can see that my colleague has taken a connective tissue graft and secured it. And then he's also sutured these 2 pedicles together and then covered up the graft and secured this entire complex. And about 1 year, we can see how amazing his root coverage is. And not only has he gotten root coverage, but he's also gotten nice thick tissue and an increase in the zone of keratinized tissue. One of my cases, which I recently saw for the 2.5-year follow-up, again, this patient was a 19-year-old girl post-orthodontic treatment, and we did a double papilla procedure where we were able to get complete root coverage, a nice increase in the zone of keratinized tissue. This result is nice and stable, and the patient's maintaining it very, very well. Now, this paper really made me think about what is really the key factor in getting successful root coverage outcomes in the anterior mandible. So you'll recall in the Harris paper that the double papilla approach and the lateral tunnel approach were the 2 approaches that were quite significant in terms of the root coverage outcomes. If I look at the numbers, there was over 90% mean defect coverage for these recessions, and with a coronally advanced flap with the connective tissue graft, it was much less. And when I thought about what these 2 procedures have in common, the double papilla and the laterally advanced tunnel, what they have in common is that they do not disturb the vestibule. So if you don't disturb the vestibule, you're not disturbing really, you're not aggravating or provoking that muscle pull, which is so strong in the anterior mandible. And then that got me thinking, maybe that is the key to getting successful root coverage outcomes in the anterior mandible, is doing a technique that does not disturb the vestibule, because the vestibule is shallow to begin with in a lot of cases in the anterior mandible. And if we coronally advance the flap, we're going to put more tension on that flap because of the shallow vestibular depth and the muscle pull. And then, of course, we're going to see some retraction and end up with the result that I showed you with at the beginning of this lecture. Then another technique, the vertically advanced flap by Zucchelli and colleagues, essentially looks at taking a recession like this, which is about 3 to 4 millimeters, and rather than doing just a coronally advanced flap, what they do is they actually remove the labial submucosal tissue to try to what they call vertically advance the flap and increase the vestibular depth. And so again, Harris's paper looked at not disturbing the vestibule. Zucchelli's paper looked at reestablishing a greater depth for the vestibule. And in their studies, they've shown successful results with this technique, both in terms of mean defect coverage and predictability in terms of complete root coverage. And this is one of the cases that I took from their paper, where you've got an isolated recession defect like this, and we're able to change the phenotype, get complete root coverage by respecting the fact that you can't just coronally advance the tissue. You have to actually be mindful of the fact that there's very little to no vestibule, and you have to recreate that vestibule. And this is one of my cases, very similar situation where there's a connective tissue graft underneath this vertically advanced flap. And at 1 year, we can see nice root coverage with a gain in keratinized tissue. Another technique that was popularized by Anton Sculian and Pat Allen, 2 very prominent periodontists, they did what's called a laterally closed tunnel approach. So you'll recall the double papilla technique, which I talked about, which was the creation of these 2 papillas that then get joined together. this is essentially a modification of that technique, except here, you're not elevating, you're not actually dissecting those papillae. You're actually leaving everything essentially intact by doing a tunnel approach. You're undermining the heck out of the tissue subperiosteally by creating a tunnel. And then they take a graft and secure it inside the tunnel, secure it around the tooth, bring the edges of the tunnel together, secure it, again, not disturbing the vestibule. So this is why they showed some tremendous success in their results as well. So pretty substantial recession. This is from their paper, and they're able to get complete root coverage. When I look at this, though, I still think that the tissue looks a bit on the thinner side. And I take one of my free gingival graft cases, which is very, very similar. And even at 4 weeks, we can see how nice this tissue looks. And this is, again, it's a very straightforward procedure. It'll take me probably a third of the time that it would take me to do a laterally closed tunnel. And even when you look at the aesthetics here, the blend of this is pretty good. And we know that this graft isn't going anywhere, even if the patient disappears off the face of the earth and comes back 6, 7, 8, 9, 10 years later. Once in a while, though, in your lifetime, you will come across a paper that really, really changes a lot of things for you. And this paper, for me, has done that. This was a paper by Stimmelmeyer and colleagues out of Germany, where they looked at treating gingival recession in the anterior mandible using a combination of a tunnel with a hybrid graft. So they left a portion of this graft epithelialized, like an epithelialized island, and then they had what was underneath the tunnel as connective tissue. So it's a hybrid approach. It's the best of both worlds. It really appeals to my love for free gingival grafts, but wanting even more predictability. Again, with this technique, no disturbance of the vestibule. So therefore, you get minimal postoperative retraction. Aesthetically, there's no concerns. And from a success and predictability perspective, it's quite high. And this is an ideal approach, really, for the anterior mandible. And I'm going to show you a couple of cases before finishing off. So here's a case, one of the first cases that I did with this approach. Now, my earlier instincts would scream at doing a free gingival graft here. But I said, hey, you know, Vinay, let's try something else. Let's step outside the comfort zone here. So we did an epithelialized island approach where we started raising a nice tunnel, or elevating a tunnel, preparing a tunnel, I guess, is more correct. And then we harvested our connective tissue graft. And you can see here that I've circled where that epithelialized island is, which is going to sit against the exposed root surface. We then place that graft carefully, and you can see this epithelialized island here. We secure the graft and the tunnel with 5-0 monocrystal sutures. Sling sutures are sufficient. And then at 1 week postoperative, it's interesting because you can see nice redness here underneath the tunnel, which means that this graft is getting nourished with good blood supply. But we see coronally what looks like a free gingival graft would be looking like at 1 week. Still, I don't get nervous because this is what a free gingival graft would look like, but I know that I've got graft underneath the tunnel, which is being nourished as well. At 3 weeks, when things settle down, we can see we've got complete root coverage, increase in the zone of keratinized tissue. And at 1 year, we have a nice blended harmonious result. Looks like the patient never had recession. And it's more aesthetic for those of us who really care about the aesthetics in the anterior mandible. But nonetheless, it opened my eyes that, hey, you know what? Maybe there are other techniques that can be as predictable as free gingival grafting. And when we look at this side by side, we can see that there's been complete root coverage compared to the preoperative. We've eliminated the influence of the frenum. We've changed the phenotype, and all in all, very, very happy with this result. Now, here's a case that I want to show you where it's a Miller class 3 or an RT2 recession where I'm not expecting complete root coverage. But nonetheless, I want to increase the zone of keratinized tissue. There is recession on the adjacent teeth, but the patient was only really concerned about this tooth, tooth number 3-1. And here it is, the CEJ. We take our graft. You can see the epithelialized island. I've prepared the tunnel, secured the graft only with sling sutures. And we can see that we have not disturbed the vestibule at all. And at 1 year, in fact, we can see an increase in vestibular depth, nice, clean, keratinized tissue, nice blend. Again, it doesn't look like a graft was even done. And we've gotten some pretty decent root coverage as well. So where am I at now? For the longest time, I thought I shared my love story with you about FGGs. And certainly it's still a workhorse in my practice. And for a situation like this, where we've got thin tissues with high frenum pull recession, where we want to try and treat a few problems with one procedure, I think an FGG is still a very predictable procedure. But I am also open to doing the hybrid approach and even the vertically advanced flap for some of these procedures, where in the past I'd say, you know what, I'm just doing a free gingival graft for this. And for more severe recessions that are more narrow, definitely a double papilla and a lateral closed tunnel. I've not done a lateral closed tunnel as yet, but I'm hoping that when the right case presents itself, that I'll be able to do that. So some final thoughts and conclusions are that root coverage in the anterior mandible, as I hope I've been able to impress upon you, can be successful and predictable, and that the free gingival graft is just as viable an option really as the connective tissue graft for root coverage, and more importantly, phenotype conversion. But the key really lies in not disturbing the vestibule or the mucogingival junction. So if you're doing any connective tissue grafting, you want to make sure that you really try and keep that vestibule intact. We don't have to really worry about that with the free gingival graft, because we're actually increasing the vestibular depth inherently just by nature of that procedure. We definitely need more studies with larger sample sizes to validate connective tissue grafting truly as the gold standard for all areas of the mouth. But classifications should also consider some degree of site specificity, because I think that success and predictability are different when you move from the anterior mandible to the maxillary anterior, for example. And I like the fact that we've got these newer techniques for connective tissue grafting where root coverage is actually quite promising, successful, predictable, and more importantly, replicable. And with that, my friends, I'd like to thank you for hearing me talk for the last hour, 15 minutes. I hope you found this worthwhile. And whether you agree with me or not, whether you're going to do some of these things in your practice or not, I hope that you're able to take something away, at least a few pearls from this lecture. I'm quite active on social media, on Instagram, where I share a lot of my cases. So please do check it out if you have some time on your hands. And also, here's my email. If you have any questions, please don't hesitate to contact me. I'm very, very happy to engage with anyone. Thank you again, everyone. Please stay safe. I'm hoping that sometime soon we'll be able to do these things in person and meet up. Really appreciate the Oak Seminar Committee for inviting me to give this lecture. And I guess now I'll take all your questions.
Thank you, Dr. Bhide. I'm going to hand it over to the moderators, and they're going to be asking you, I'm sure, the plenty of questions that people have posed tonight.
Thank you.
That was a great lecture, Dr. Bhide. I wish you gave us that lecture earlier on in my residency career, because I think you've converted me.
Converts are always good.
The first question from the audience is creeping attachment also observed in the maxillary teeth in addition to mandibular teeth?
So the question is this, you see creep in maxilla as well?
Yes.
Yeah, you see creep anywhere. And in fact, you probably see it more in the maxilla because gravity is on your side in the maxilla. So the fact that it happens in mandible is actually quite special because you're actually working against gravity.
Perfect. I think Sonia or Charlie has a second question.
Thank you very much, Dr. Bhide, for such a fantastic lecture. I'm sure all residents learned a lot from today.
Thank you.
So I have the next question here. Have you come across any literature or studies looking at the mechanism of the creeping attachment that we see from FGG? Yeah,
so in the paper, one of the original papers by Matter in 1980 that actually talked about creeping attachment, they do talk about mechanisms, and what they think is actually happening is that there's granulation tissue formation that is leading to keratinization, and hence you get this migration of the gingival margin, but it's still sort of unclear as to why that happens. I mean, I can show you photos from earlier where, you know, the first case that I showed you, like my turning point case, if you remember between 6 months and 1 year, there was like a little bit of a delineation between the new attachment versus where it was at 6 months. And I think it's a combination of coronal migration with granulation tissue formation as well.
Great. Thank you.
Thank you, Dr. Bhide. Another question from the audience. What can be done for the black triangles? What coverage is usually seen with grafts in sites with black triangles?
So the honest answer to that is there's really nothing predictably that can be done specifically for the black triangles themselves. If we do a root coverage procedure and happen to get some resolution of the black triangles, I would say it's more luck than anything. There are methods that are being investigated in Toronto, actually, at Mount Sinai Hospital, where they're looking at dermal fillers to inject into the papilla as a way to try and decrease the incidence or the prominence of those black triangles. But from a root coverage perspective, it's really nothing that I could tell you to do specifically. If it happens, I'm happy it happens, but I can't tell you why it happens, really.
The next question is, what do we do with teeth that already have a class 5 restoration?
Oh yeah, that's the big question. For class 5 restorations, if the class 5 restoration is intact, and I don't see any evidence of marginal leakage or anything, and it's in a non-aesthetic area, my tendency, honestly, is to leave it, because I don't know how deep that restoration extends buccolingually. But if we've decided that we're going to do a root coverage procedure because the tissues are thin or the patient just wants to have a procedure done, I will have the restoring dentist remove that restoration prior to me seeing them for the graft. Now, how deep that restoration extends can have an impact on your root coverage outcomes. If it extends more than a couple of millimeters, then you may want to think about using a material like Gerastore, which can actually adhere to tissue to try and reduce the prominence, or the reverse prominence of that of the cavity. If it's less than 2 millimeters, then all systems go for a root coverage procedure. I'm not the most talented restorative dentist in the world, so I try and leave that stuff to the restorative dentists. But I know a lot of my colleagues will remove the composite resin. Now, the other thing too is that you also want to know where the CEJ is. And so if you can anticipate where you want the CEJ to be, you can artificially essentially make a CEJ by revising that class 5 restoration, so that at least you know that you're going to get root coverage, hopefully up to that point.
Thank you very much. Charlie, next one.
Dr. Bhide, so how often are you performing these procedures because of patients concerned with the aesthetics? We know from the literature, patients and dentists disagree on aesthetic outcomes. Do you ever find that aesthetic-driven patients are not happy with the tissue blending and aesthetic outcome with pregingival graft?
So a lot of it depends on your patient expectations and how you prepare that patient. So in the anterior mandible, my primary goal isn't aesthetics. It is function, it is root coverage. And of course, I will try and do a graft in such a way that the blending is more seamless. Like, the old school, like the really old school free gingival grafts, they look like denture phalanges, like they're super thick and very, very meaty. Now we know that a 1.5 millimeter thickness of graft tissue can actually have a very, very nice blend. Now, as far as aesthetics go, I will tell the patient right off the bat at the consultation, the gum tissue here is not going to look like the surrounding gum tissue, because the color of the palatal tissue is slightly different than the mucosa in the anterior mandible. And anyone that looks in your mouth is going to know that something was done. And so I actually get them to smile so that I can verify with them that they're not showing any gum tissue. Most people don't show gum tissue in the mandible, but once in a while you get the odd patient where you can see their gum tissue in the mandible as well. So I make sure that it's not in sight, and then I tell them that this is likely going to look different, but we're not doing this procedure for aesthetics. And once they know that, I have very few patients say, I'm very unhappy with this, because have I taken away their sensitivity or eliminated it? Yes. Have I gotten root coverage? Yes. Have I set them up for success in the future in terms of stability? Yes. And those are the points that I highlight with them as well.
There's a related question here. if you want to do two free gingival grafts on two like adjacent areas in two separate surgeries, how do you blend the two tissue together? That's another question.
So I just want, I'm wondering, okay, let's assume that these are two teeth that are adjacent to each other. In that case, I'd probably just do one procedure. Like I wouldn't do two grafts separately because it's not easy to blend. It's not also easy to prepare a recipient site that is actually made up of an FGG done previously. But if I'm doing two teeth that are like, let's say 4 or 5 teeth apart, either I could do one at a time or I could just do both at the same time. I generally don't like to do free gingival grafts in two adjacent teeth unless that patient needs a free gingival graft and has been referred to me and the graft has been done previously by somebody else.
Great, thank you. Sonia?
Another question, is there, besides the hard palate, is there anywhere else that you can take the graft from to use for FGG?
Yeah, the only other place is some patients have really, like I said, like the old school free gingival grafts that are very thick and wide. There's actually some literature looking at taking strip free gingival grafts from previously grafted sites, but they're more for areas where you're just worried about increasing keratinized tissue. I don't know if you'd get enough for root coverage. So it's really the palate, perhaps the tuberosity, but the tuberosity is more for connective tissue harvesting. But really, the hard palate is the way is a place to be.
The next one is for patients who come with sensitivity, how successful do you find FGG in reducing the patient's sensitivity?
Well, if you get root coverage, then you're very successful. Do I promise patients that I'm going to eliminate their sensitivity? Of course not. I will always say to them that they still may have sensitivity after this procedure, but if we get root coverage, it should be less, and whatever's remaining, we can treat non-surgically with desensitizers or Sensodyne toothpaste or the equivalent.
You're up, Charlie.
Got lots of questions. Okay, how would you treat very deep recessions where you're not able to harvest the graft large enough to cover the recipient bed in all dimensions, especially at the apical portion of the bed?
So so for a deep recession like that, I would do either a double pedicle or a laterally closed tunnel, because I know for those with a connective tissue graft, because for those procedures, I don't need to have a long piece of graft tissue. I only need a piece that's about 4 millimeters, 5 millimeters long by usually about 10 millimeters wide. And then the papillas or the buccal tissues will cover that graft and help nourish that with good blood supply. But if we're talking free gingival graft for a deep recession, I typically don't do that anymore, specifically for the reasons that the person asking the question was saying.
Okay, thank you. Sonia?
The next question, when is the zone of attached tissue considered minimally attached? Is there a specific number or measurements?
Ooh, good question. So we typically use like 1 millimeter or less as minimally attached, and greater than 1 millimeter is not minimally attached. And that's oftentimes accompanied as well by zone of keratinized tissue. And so studies in the 70s looked at whether there is a certain zone of attached gingiva that's necessary to maintain periodontal health. On the one hand, you had a school of thought that was saying that you should have at least 1 millimeter of attached gingiva with 2 millimeters of keratinized tissue to ensure health, and another study that showed that there's really no minimal amount of attached gingiva that's necessary for periodontal health. Now, both of these studies have different methodologies, and again, this is one of those topics where, in dentistry, there's a lot of the problem with dental research, and I don't mean to be long-winded about this, the problem with dental research is that we just don't have sufficient numbers to be able to draw definitive conclusions. And just like with keratinized tissue, with attached gingiva, I can tell you that just because the literature doesn't say that you must have this amount of attached gingiva, it doesn't mean that it's not important. And if you talk to many clinicians anecdotally, you want to have at least 1 millimeter of attached gingiva. And we know from the literature as well that came out later that a thin phenotype with a minimal attached gingiva is more susceptible to recession in the future, even in the presence of good oral hygiene. So definitely, I think we do need some attached gingiva because that is providing some protection against bacteria from getting underneath. So I try and make sure that there's at least 1 millimeter or 2 millimeters following procedures that I do.
Thank you.
Another question is, do you use Copac on your surgical sites, the recipient site?
I don't use Copac on the recipient sites, and I'll tell you why. It's because I'm just afraid that when the patient comes back at 1 or 2 weeks, that I'm going to take the Copac off and the graft is going to come out with it. Like, it's just sort of one of these nightmares that I have metaphorically. So I don't, and there's no literature suggesting that it really matters. In fact, I would say it impedes healing more than it helps healing in the recipient site.
Perfect, thank you. Charlie?
Has the findings related to the anterior mandible changed your way of thinking of doing FGG versus connective tissue in other areas of the mouth? That was one.
Yeah, so a great question. The only areas of the mouth that actually do FGGs are in the anterior mandible and sometimes in the posterior mandible. But I find it's not easy to do them in the posterior mandible just because of access and shallow vestibular depth. So it for me is really more or less exclusive to the anterior mandible. Everywhere else, it's connective tissue grafting. But for molar recessions in the maxilla and the mandible, I've started actually using that hybrid technique that I talked about with the epithelialized island. And I've been getting some really, really nice results with that satisfy my need for wanting to get root coverage, as well as having good keratinized tissue around that area as well.
Thank you.
Next question. How do you prevent the rare post-op complications of pouch formation in the vestibule?
Oh yeah, so that's a tough one to answer, because sometimes you think you've done the perfect graft and then you get this this pouch. And I think by pouch, I think the person asking questions is referring to the space between the apical extent of the graft and the alveolar mucosa. The best way to really mitigate against that is by having airtight suturing. So in addition to my interrupted sutures, I'll have 1 or 2 compression sutures that have really good horizontal adaptation of the graft to the recipient site. And even after the surgery, I'll always take some moist gauze and sit there for about a good 2 to 3 minutes, just putting pressure to the graft and to eliminate the dead space, so that way I've noticed a much lower incidence of pouch formation.
Thank you.
Last question, Dr. Bhide. When you do that epithelial island, it'll slough off anyways. What's the difference? Doesn't it slough off?
Yeah.
But
sorry. Finish the question. Yeah. I'm sorry to interrupt.
Yeah. So what's the difference if you do a CTG without the epithelial island and leave a bit exposed? Because that connective tissue will eventually form epithelialized, form keratinized tissue anyways, right?
So the benefit of the epithelial island is that, so if you do a connective tissue graft with a small epithelial collar, right, you're still doing a coronal advancement that's disturbing the vestibule. So in the maxilla, it doesn't really matter. But in the mandible, where like you really don't want think about the vestibule and the anterior mandible as sacred. You don't want to touch it, or if you do, you just want to make it better. And so with the epithelial island, it's essentially customizing the amount of epithelium that's going to sit against that root surface, so you don't really have to advance that flap coronally. You follow? Yes. So conceptually, there's not. Yes, it will slough and it will keratinize, but I know that I'm not disturbing the vestibule at that same time, and I think it will lead to a better outcome and better blending in with the surrounding tissue.
So let me get this correct. you're not advancing your flap as coronally with the epithelial island.
That's right.
So, but the thing is, you could do a connective tissue graft without advancing it. So the same amount of advancement and leaving some of the connective tissue exposed. And
Right.
wouldn't that become?
Yeah. So in the paper by Stimmelmeyer that I talked about, the last paper that I talked about, they address that. They say, why not just leave connective tissue exposed? The reason for that is because that epithelium, yes, it's going to slough, but it provides a protective barrier against the underlying connective tissue, right? It's the same reason why when we do a free gingival graft, why not just deepithelialize the free gingival graft and leave an exposed connective tissue? It just doesn't heal in the same way because it's already subject to the harsh environment of the mouth. So that epithelium, if anything, is more protective than just leaving naked connective tissue exposed.
That's perfect. Thank you very much, Dr. Bhide.
Thank you.
Okay, so that's it for today. I know that there are lots of questions coming in, and if we tried to get through them all, we'd be here about another hour. So if you have other questions, do stay tuned for more seminars. Also, as Dr. Bhide mentioned, please feel free to contact him. We also have a contact that's going to be made available for email to Oak Seminars for any inquiries as well. So I want to thank Dr. Bhide very much for his amazing presentation. Everybody seems to have enjoyed it from the feedback that we've received so far. We're very, very happy to have had you here tonight. So thank you, Dr. Bhide. We really appreciate it.
Thank you.
For more information, please go to our website, the U of T webpage, and the Oak Seminars tab to find out who's presenting next. And so we have a little sneak peek of who's presenting next, which is on January 25th. So in 2 weeks' time, we have Dr. Rodrigo Navia, and he's going to be talking about dealing with ridge deficiencies, graftless, and graftless options. And then in 2 weeks from that, we have Dr. David Wong, who's going to be presenting on soft tissue management around dental implants. So feel free to take a browse through the website, register in advance for all the seminars you'd like to attend, and we'd be happy to have you. Thank you, Dr. Bhide.
Thank you. Good night, everyone.
Good night.